Hello and welcome. Thanks for joining us today. My name is Amber Nagebauer. I'm one of the third-year emergency medicine residents at the Christus Health Texas A&M Emergency Medicine Residency Program in Corpus Christi, Texas. The study of my project is return visits within 30 days following an evaluation for hyperglycemia in the emergency department. I'd like to begin by thanking my co-authors, Drs. Shu, Ponder, Herrick, Torres, and Richmond. I have no disclosures, financial or non-financial. By way of introduction, the National Diabetes Statistics Report of 2020 reported that roughly 34.2 million people in the United States have diabetes. This is roughly 10.5% of the United States population. In 2015, diabetes became the 7th leading cause of death in the United States. It is currently the most prevalent chronic disease among all ED patients. And diabetics have roughly twice the number of ED visits as non-diabetic patients. Rates for diabetes continue to rise the most in urban areas of the United States. There is a disproportionate disease burden suffered by minorities and low-income populations. Patients of lower socioeconomic classes and no established primary care provider have been found to have higher emergency department utilization rates. Insulin dependence may also indicate more poorly controlled blood sugars, and these patients may be more likely to seek care. A study evaluating all return visits to the emergency department found that roughly 2% of patients returned to the emergency department following an initial visit. 85.1% of patients returned due to persistence of illness or symptoms, 12% returned due to wrong initial diagnosis, and 2.9% returned due to an adverse event related to their initial treatment. Emergency department overcrowding and lengthy ED wait times are seen in many hospital systems in the United States. Recurrent ED visits for several medical conditions have been researched. Many patients with recurrent ED visits have limited access to care. There is a relative paucity of research regarding emergency department visits for diabetics and their repeat ED visits and reasons for those. The objective of our study was to determine risk factors associated with repeat emergency department visits within 30 days following an index hyperglycemic encounter in patients with diabetes. In terms of methods, our study design was a retrospective multi-center cohort study. The study group were patients with an ICD-9 or ICD-10 diagnosis of hyperglycemia, DKA, or HHS over a 5-year period of time. The study setting was an academic, urban emergency department and 4 system-related, community-based emergency departments. The study protocol: index and subsequent hyperglycemic emergency department visits within 30 days were identified in the EMR. Data points from the patient's initial ED visit were analyzed. A second blinded author reviewed a sample of records to assess for inter-rater reliability. The primary outcome of our study was to identify patients' characteristics associated with ED return visits. In terms of statistical methods, categorical data was analyzed by chi-squared, continuous data was analyzed by t-tests, multivariate logistic regression, which included index visits for patients' characteristics, was performed to control for confounding, and an odds ratio was calculated. Our results yielded 327 patients in all were evaluated. The mean age was 53. 69% of patients were female, 81% of patients were Hispanic, 78% had a primary care provider, 40% had primary insurance coverage, 33% used subcutaneous insulin, 20% utilized combination oral and insulin therapy, and 52% had an initial glucose over 360. The evaluation of the cause of the hyperglycemia was determined in 29% to be noncompliance, and in 56% of patients to be underdosing. Populations with recurrent ED visits within 30 days was roughly 30% of the study group, and 17% of these patients were discharged on subsequent visit. By variant analysis, the following variables were associated with return visits in 30 days: medication type, medication noncompliance, and discharge on index visit. Using multivariate logistic regression, the following were associated with increased risk of return in 30 days: This included female, gender, and combination oral and insulin therapy. The inter-rater reliability for our study was nearly perfect for all data points. This included medication type, medication noncompliance, ED disposition, return for hyperglycemia, 30-day outcomes, and the number of repeat ED visits. In terms of discussion, there is a significant disease burden. Roughly 34.2 million people in the United States have diabetes. As mentioned before, this is roughly 10.5% of the United States population. There are high rates of ED utilization by diabetic patients, and there is a current lack of research determining reasons for repeat ED visits in this patient population. There was a similar study that was performed. Yan et al. Found risk factors for recurrent emergency department visits for hyperglycemia in patients with diabetes. This study was a one-year review of patients. It was a retrospective, multi-center cohort study, and it evaluated return visits in 30 days. There was a difference in methodology of our two studies. This included the population demographics. Their study was a Canadian study. In their study, there's roughly 3.0 million Canadians that have diabetes. Generalized estimating equation was used in their study to account for patients with multiple visits versus our study, which evaluated the index visit. 81% of patients in our study were Hispanic. Their study identified 5 risk factors associated with return visits in 30 days. These were previous visit for hyperglycemia in the past month, age less than 25 years, glucose greater than 360, being on insulin, and having a primary care provider. Female gender as a risk factor for repeat ED visits and hospitalizations has been found in several studies before. Rowe identified female gender as one of 3 risk factors associated with recurrent readmissions in asthma patients. Sykes identified female gender as one of 5 risk factors for increased readmission rates to the critical care unit for recurrent DKA within 1 year. Combination of oral and insulin therapy as a risk factor was also identified in the Yan et al. Study. Patients using insulin had higher rates of ED recidivism. The use of insulin tends to be delayed, while other treatment options are used initially. Patients on insulin are less likely to be well-controlled diabetics and are more likely to have progressive disease with irreversible disease complications. Insulin dependence may indicate more poorly controlled blood sugars. The limitations of our study included reliance on correct ICD-9 and ICD-10 coding of diagnosis. If patients presented to the ED and were found to be hyperglycemic but also had another leading diagnosis, they may have only been diagnosed with that and not also diagnosed hyperglycemic or in DKA or HHS. Patients with index visits were utilized to identify risk factors. The associated recurrent visits were not evaluated. Each subsequent visit was not evaluated for these risk factors, and the socioeconomic and level of education factors could not be assessed because these elements were not reliably documented in patients' charts. In conclusion, within our cohort, diabetic patients with an index presentation of hyperglycemia were more likely to return to the emergency department if they were female or if they utilized combination oral and insulin therapy. Thank you.